Hi everyone, welcome to the finals crash course series on dermatology. My name is Nazifa and today I'm going to be teaching you guys a bit about some emergency dermatological conditions and a few other interesting derm stuff. Before we get started though, if you guys would like to follow our Instagram page, you can see the QR code in the top right hand corner. Please do follow us on Instagram. And if you guys have any questions after the session, please feel free to send us an email. The email is down on the bottom left-hand corner. We will you can answer some of the questions that we have on the presentation through Vvox. I've just put the link up on the chat. If you guys feel free to join in and have a go at the questions and I can see what everyone is thinking. The QR code is on the presentation slide as well. So without further ado, let's get started on the first SBA. A 75-year-old woman presents with an itchy, blistering rash. Examination of her mouth is unremarkable. What do you think the skin condition is? So I'll give you guys about 30 seconds to answer this question. Okay, so correct. The majority of you guys have answered D, bullous pemphigoid. So I'm going to go over each of what these conditions are in a few moments, but just to summarize. So the reason why it's bullous pemphigoid is this is an autoimmune skin condition. What you tend to get typically in SBA situations is that you don't get any mucosal involvement. And in an SBA scenario, that's a key differentiator to another autoimmune skin condition called pemphigus vulgaris. Both conditions present in this itchy, blistering sort of rash, but the severities are quite different between the two, and I'm going to discuss that in a moment. Dermatitis herpetiformis is another autoimmune skin condition, but you tend to get that in relation to people who have celiac disease, and it presents quite differently, not with blisters, but what you get is more of a itchy vesicle type rash. So it's quite different in presentation. And epidermolysis bullosa, I don't know much about this skin condition. From my understanding, it's quite a rare condition, also associated with blistering, but it is very rare. Yeah, I don't know much more about it, but it's very, very rare. So the answer in this situation is bullous pemphigoid. So to go over the details of what those conditions are. So firstly, with bullous pemphigoid, as I mentioned previously, it's an autoimmune skin condition that tends to affect your subepidermal region. So if you think about your layers, your top layer is your epidermis, then you have your dermis, and then you have your subcutaneous fat. So your bullous pemphigoid affects that subepidermal region. And what you get is you get autoantibodies against a particular protein called hemidesmosomes, hemidesmosome protein. And as a result, you get this kind of linear pattern on immunofluorescence. Now, the reason why I'm being that specific about it is that you might sometimes get SBAs which mention this linear immunofluorescence pattern, and they might mention this idea of antibodies being found in the subepidermal region. Now, the thing with bullous pemphigoid is that it tends to affect people in the more elderly range, so sort of 80 plus. And what you find with the blisters is that it is tense and itchy in presentation, but key in SBA land at least is that it tends to avoid, or you don't tend to find it in mucosal areas. And actually you treat it usually with oral steroids. Sometimes you can even do topical therapies if it's in a localized region, but it is quite a common presentation, and the patients with it are usually generally systemically okay. Now, this is quite different to pemphigus vulgaris. Now, pemphigus vulgaris is also another autoimmune condition. However, you find autoantibodies against the protein desmoglein in the intraepidermal layer, and you get this kind of net-like pattern on immunofluorescence. Now, the key difference with pemphigus vulgaris is that number one, the patients tend to present much more severely. So you require more systemic treatment with steroids and immunosuppressants. And the blisters as well, they tend to be more flaccid, they rupture easily. And key, at least in SBA land, is you tend to get mucosal involvement. So you will find lesions, say, for example, inside the mouth. And you tend to get what's known as Nikolsky sign positive. And what that means is that when you touch the skin kind of peels off. So its presentation is a lot more intense, essentially. So the key thing with bullous pemphigoid versus pemphigus vulgaris, with bullous pemphigoid, you tend to get these tense blisters, and you don't find it in the mucosal area, at least in SBA land, and you treat with more oral steroids, sometimes topical. With pemphigus vulgaris, it's much more rare, but it's much more intense in terms of its presentation, and you will often get flaccid blisters, and you will find it in more mucosal, you will find a mucosal involvement, and it will require more systemic treatment. SBA2, a 40-year-old man presents with a 2-week history of an intensely itchy rash just below his knees and on his elbows. He states that the rash has responded poorly to an emollient cream. On examination, he has a symmetrical vesicular rash as shown. He also describes experiencing diarrhea and does not appear to be putting on weight. Given the most likely diagnosis, which of the following is the most appropriate management for this condition? Again, I'll give you guys 30 seconds or so to answer the question. If I'm going too fast, by the way, for anyone, just please do let me know. Okay, so the majority of you guys have chosen B, topical steroids. However, actually, the most appropriate the answer is C, so gluten-free diet. So what this rash is indicative of is dermatitis herpetiformis. And you might have remembered in the previous SBA, I mentioned that this rash is associated with celiac disease. So number one, with this rash, you tend to get these itchy vesicular skin lesions in the extensor surfaces, as you can see in the image. And in terms of the history of this patient, he sort of describes this diarrhea and not being able to put on weight. Now, I understand that it's quite vague, so I do apologize for that. It is quite vague. But in terms of the presentation of the rash, what you might want to be thinking is someone who has celiac disease, especially with this weight loss that he's describing. Now, one of the first things that you would obviously want to do is a gluten-free diet if you've got celiac. And another thing as well that you might want to consider is a cream called Dapsone, not topical steroids. So Dapsone is a type of antibiotic actually that they can use in dermatitis herpetiformis. The reason why it works, I don't know the exact mechanisms, but it has something to do with neutrophil action and reducing neutrophil recruitment and function. And yeah, so that's what the cream is meant to do. So actually, that's one of the first line treatments for dermatitis herpetiformis. So yeah, as I mentioned, it's an autoimmune skin condition associated with celiac disease. You get these itchy vesicular skin lesions. Your diagnosis is through a skin biopsy, or you can essentially diagnose as well the way you would do celiac disease with or looking at immunoglobulins as well. And the management is gluten-free diet and dapsone. Those are the first step in management. SBA 3, a 35-year-old woman comes to the office because of an extremely itchy rash on her wrist. She says that it has started 4 days ago. Physical examination shows several small violet papules on the anterior wrist. Which of the following findings is most likely seen in this patient? So I will give you guys about 30 seconds to answer. Okay, so the answer to this question is A, Wickham's striae. So what this SBA is trying to get at is a condition called lichen planus. So lichen planus is a autoimmune disorder. People don't really know what the pathophysiology is behind it exactly, but some common triggers that you might get is gold, thiazides, and quinine. And what you essentially get is this really itchy lesion, usually found in your wrists or your ankles. And there's a mnemonic that sometimes is used called the 4 Ps of LP, meaning the 4 Ps of lichen planus. Those being polygonal, purple, puritic, and papule. So here's a picture of what lichen planus looks at. So polygonal meaning, I guess, sort of shaped in a weird way. Purple meaning it's color purple. Puritic meaning it's itchy, and papule meaning you sometimes find it as a raised lesion, and sometimes it might look almost like a plaque. What you also might find with lichen planus is this kind of white lacy network, or this white lace pattern that you find in mucosal areas. So, for example, in the mouth, and that's what is known as Wickham's striae. Wickham's striae is associated with other conditions as well, but one of the big ones is lichen planus. One thing to remember with lichen planus is it is also associated with hepatitis C. So when people do present with this, you might want to test them essentially for hepatitis C as well, particularly if they've got oral lichen planus or Wickham's striae. You would want to test them for hepatitis C. The management for this is just with topical steroids. You can also use oral steroids if I guess it's more systemic in nature, and if it gets really bad, you can also do immunosuppressants. Now, why are the other questions answers wrong? So positive Nikolsky sign, I don't know if you guys remember, I've mentioned it briefly, but that's essentially when you rub your skin and your skin comes off. So that's clearly not what it is. Leukoplakia is a white patch that you might find in someone's mouth. It tends to be painless in nature, and it's actually a pre-malignant condition. And you can differentiate it from oral thrush because when you scrape the white patch, it won't come off. And purpura is just a non-blanching rash as a result of breakage in small blood vessels. So none of those is indicative of the presentation in the SBA, which is these small violet papules. Oh. SBA 4. A 15-year-old boy attends to the GP with a rash. He had a mild cold the last few days, but is otherwise well. On examination, there is a 2-centimeter discoid red patch on his left arm, which he mentioned started 3 days ago, and many smaller rashes on his back. Which of the following is the most appropriate next step in management? So I will give you guys about 30 seconds to answer this question as well. Okay, so the answer to this question is E, reassure and discharge the patient. So 15-year-old boy, he comes in with a cold and then he gets this discoid rash on his left arm, which started 3 days ago. And then he got these smaller rashes on his back developing. So what is that rash? What this is trying to talk about is something known as Pityriasis rosacea. So Pityriasis rosacea is a acute self-limiting rash that tends to happen due to this virus called HHV7. Now, what you tend to get with it is you get someone who has a bit of a cold, and then they get this discoid rash, also known as a herald patch. And then a few days afterwards, they will get this more widespread rash, typically along their back. And it's the pattern, the phrase that they use in the textbooks at least is this fir tree appearance or Christmas tree pattern on their back. So what you'll get is the herald patch first, this circular kind of lesion, and then later on you'll get this widespread, a few days or weeks later, maybe you get this widespread rash in this Christmas tree pattern. And this rash is completely self-limiting, so it will disappear on its own after a few weeks' time. If it's itching or anything, you might want to consider giving topical steroids to reduce any inflammation, or giving any oral histamines or antihistamine, sorry. But it should go away by itself. So that's why for this question, that was the most next appropriate step, because you wouldn't want to jump into giving any topical corticosteroids. You'd want to reassure them, discharge, and then if it's not resolving, then they can come back. The other SBA, so topical vitamin D analog, that's a treatment for psoriasis, of which there's no indication in this SBA. Topical retinoid is for acne, and acne doesn't present in this way. And a topical antibiotic cream, while there's no suggestion that any of these rashes have become infected, so something like any pus coming out of it, or if he's systemically very unwell, in which case you probably want to give oral antibiotics anyway, but there's nothing to suggest that any of this is infection. So that's why the answer is E. SBA 5, a 50-year-old man with a history of type 2 diabetes and penicillin allergy comes to the office because of a painful facial plaque. Physical examination shows a shiny erythematous plaque involving the central face with sharp raised borders. On palpation, the skin is soft and tender. Which of the following is the most appropriate medication for this patient? I meant to say on palpation or palpitation, but anyway, I'll give you guys 30 seconds to answer that. Okay. So the answer to this question is A, clindamycin. So what is this SBA trying to get at? So he's got type 2 diabetes, he's got this red plaque on his face with these sharp raised borders, and when you touch it, it tends to be tender, although soft, so it's tender. So what this rash is trying to get at is something called erysipelas. Now, erysipelas is essentially a form of cellulitis, but it tends to be more superficial, and you might get lymph node involvement. Now, why might you be thinking in this case he's got cellulitis or a form of cellulitis? So number one, he's got type 2 diabetes, so he is just fine, he's at high risk of certain infections, in particular cellulitis as well. And he's got this tender skin, and cellulitis as well will present as a red rash. And he is penicillin allergic, which is why you're giving clindamycin instead of the other penicillins. And so that's what's key in this case, because I guess technically you could give some of these medications bar fluconazole in the context of cellulitis, but he's penicillin allergic, so you can't. So obviously penicillin V is a type of penicillin, so he can't give that. Fluconazole is a type of antifungal, so that wouldn't be appropriate in this case. Ceftriaxone and amoxicillin, of course, are also types of penicillin, so it's contraindicated in this person, which leads you to clindamycin. Now, why does clindamycin work? So firstly, with cellulitis in general, so I'm sure you guys have all heard of what cellulitis is. It's basically a skin infection. You might get it because of a breach in the skin, from microscopic changes, or from certain bacteria which just invade into the skin in general. And how it typically presents is this kind of erythematous rash with quite it might actually present firstly with distinct borders and then gradually becoming indistinctive in terms of the border, and you will get this warm limb. You might get swelling as well, causing kind of edema and a lot of tenderness, and you usually find it in extremities of people. So you can see in the picture this person has quite bad ankle cellulitis. Now, the most common cause of it is Staphylococcus aureus, but it can also be caused by strep pyogenes, and there's also a bunch of other loads of different bacteria that can cause it, but the most common one is Staph aureus. Now, how you deal with cellulitis is, if it's mild to moderate, you might want to use, you would start with flucloxacillin because it covers both of staph and streps. If you're pen A, you give clarithromycin. If the infection is near your eyes or nose, you might want to give coamoxiclav instead. Again, if you're pen A, clarithromycin with metro. If the infection is near your eyes or nose, I don't actually know why it's with metro in that case. These antibiotics are, by the way, from the NICE guidelines. If it's more severe, though, you might want to go in with IV methods, in particular IV coamoxiclav. And if you're thinking it could be MRSA, you use vancomycin, or these are ticapaning or linezolid, which covers for MRSA bacteria. The key thing with cellulitis, though, is that sometimes because of the way that it presents, so for example, you get a red, painful ankle, red, painful shin, for example. It can also be confused with DVT because of the way that it presents. So in general, if you've got someone with this hot red leg, you would also probably want to rule out DVT as well, because it won't necessarily be harmful, but just do bear in mind that cellulitis is a differential too. And then there's another condition called necrotizing fasciitis, which is essentially a bacterial infection that causes tissue necrosis. And in that, it's quite a more severe presentation. So you get pain out of proportion, despite lots of pain relief. And you might get some crepitations if you get gas-producing organisms present. And yeah, they would just be really, really sick, basically. So those are some differentials for cellulitis. Now, in terms of when you might want to give IV antibiotics, so there's something called the Aron classification of cellulitis, and you can see it on the slide here. But essentially, you might want to consider giving IV antibiotics if they fall under class 3 or 4, which means that they have systemic upset, or they've got limb-threatening they've got their limbs being threatened essentially because of how bad the cellulitis is in terms of necrosis of the tissue, or they could also just be really badly septic. If they're having a rapid deterioration, if they're really, really young, so meaning under 1, or if they're immunocompromised, if they've got any facial or preorbital cellulitis, and if they've got significant lymphedema, you might want to consider giving IV. A lot of this in just practice is just looking at the patient and seeing, clinically, do they look really unwell or not from this cellulitis? And sometimes, especially in the case of people who are at high risk, so diabetes as well, because to an extent they might be a little bit immunocompromised, you might want to give them IV earlier on, just to get on top of that infection. Now, erysipelas, so that is a form of cellulitis that's more superficial, and you will get lymph node involvement. And what you tend to get is these raised erythematous lesions that's well demarcated. And you will often, sometimes it will spread quite quickly, causing systemic involvement. And you treat it the same way that you would do with any other form of cellulitis. So I mentioned here the antibiotics. As I said previously, all of these and this guideline of management is found in the NICE guidelines for the treatment of cellulitis, and I would recommend you guys have a look at that afterwards if you get the chance. Hey, SBA 6. A 10-year-old boy presents to the emergency department with a rash. The patient's mother reports the rash began on the head and spread to the chest. 1 week earlier, the patient had a cough, runny nose, and high fever. The patient had no known drug allergies and an unknown immunization status. His temperature is 40 Celsius. Physical examination reveals a macular papular rash on the head and trunk, which is a most likely diagnosis in this patient. So 30 seconds. So this might be a hard question, particularly if you haven't covered your peds rotation yet. But firstly, before I go into the question, just defining what all of these conditions are. So German measles is talking about rubella. Fib disease is talking about erythema infectiosum. And then, yeah, so that's what these two are. And then rosea, measles, and chickenpox are the conditions that you might have heard of as well. So the answer to this question is measles. Now, why is it measles? Okay, so I'll just show you this picture first. So measles, which you can see here, is caused by an airborne virus. And the thing is with measles is if someone comes in with measles or a child comes in with measles, you need to put them into a side room ASAP. And you need to make sure people are wearing masks around them because it is highly contagious. And you might want to vaccinate household members if they aren't immune. Now, what you tend to get with measles is you get these prodromal symptoms of fever, conjunctivitis, you might get cough and coryzal symptoms, so just basically generally feeling unwell. And the key thing that you might see in SBA with measles is that you get something called Colpic spots, which are these tiny white spots found in their buccal mucosa, so within the cheeks, for example. And then after this fever, you get, well, not necessarily after this fever, but then you then progress into getting this macular papular rash that starts from the head and around the ears and eventually spreads downwards to the rest of the limbs. And whilst they're having this rash, they will also usually have a fever. And that's quite key. So with measles, you get these prodromal symptoms of just generally feeling unwell. You'll get these Colpic spots inside the mouth. You get a rash starting from the head and going down. And whilst you have this rash, you also tend to get people, they tend to also be feverish. So with this SBA, you can see he's had 1 week earlier, he had cough, runny nose, and high fever. So he had these coryzal symptoms. He then had a rash starting from the head and spreading down the rest of the body, and it's macular papular. And he still has a temperature of 40 Celsius. You get this rash concurrently with this fever. If people have measles kids, just a side note, they need to stay away from school from the onset of the rash for at least 4 days, and you need to let public health England know. But I'm sure there's probably a peds session going on as well, so I'm sure they would have discussed that anyway. Now, the reason why I make a point of being quite clear about the history that you tend to see with measles is that it can be quite difficult to differentiate from the other pediatric skin conditions. So rubella, you kind of presents kind of like a milder form of lesion. So you also get this low, you kind of get this fever, tends to be a bit lower than you would get in measles. And you also get a rash as well that tends to start from the head, is particularly behind the ears. But what you get with rubella is you tend to get more lymphadenopathy involvement. And that can sometimes actually happen before even the rash takes place. So that's what's really key with rubella, is that you get this rash more behind the ears, and you can sometimes get lymph node involvements quite early on. And the fever, as I mentioned, isn't as high as it would be in measles, so they're not usually as sick. The thing with rubella is that if you are around pregnant women, they're at risk of getting congenital rubella syndrome. So with all of these, to be honest with you, the peds infectious diseases, you want to stay away from pregnant women and people who are immunosuppressed in general. With rubella, they need to stay away from school for at least 5 days after the onset of the rash. And again, you need to inform Public Health England. Now, rosea is, and again, another type of peds rash. It's caused by the herpes virus 6. And with rosea, you get a high fever that usually lasts 3 to 5 days, and then you get the rash starting. So it doesn't usually have the rash and the fever happening concurrently. And the thing with rosea, you might have heard if you've done peds already, is that it's quite often associated with febrile seizures. So that's during that initial high fever stage in the first 3 to 5 days of the disease. Fifth disease, also known as erythema infectiosum, is caused by the parvovirus B19 disease, and you guys might have heard this as presenting with slapped cheeks. And so that's what you tend to get with these people, and that's a key differentiator that you'll see in SBAs. You'll get this kind of description of a slapped cheek. Again, with these infections, you want to stay away from pregnant women because it can lead to hydropsophotialis, so the baby essentially dies. And yeah, so this one is slapped cheek. Then the other stuff, so chickenpox, I think it's quite you guys will know how chickenpox presents. You get more of a vesicular rash, might be fluid filled as well, and very itchy. And hand, foot, and mouth disease is caused by Coxsackie virus, and it is what it says on the tin. Basically, you tend to get these pus-like lesions in the hand and the foot of an individual, or vesicular, lesions in the hand and the foot of the child. So just to go back with this question, it's measles because of the way that the rash is presented from the head going downwards with a fever happening concurrently. German measles, aka rubella, tends to present as a more milder form of measles, and you tend to get lymphadenopathy earlier on. Rosea, you tend to get a very high fever and then a rash starting. And then fifth disease, also known as erythema infectiosum, is your slap-cheeked rash. And then chickenpox is chickenpox. Okay, SBA 7. So a 22-year-old is admitted to the intensive care unit with extensive blistering and necrotic skin rash affecting the whole body, including the mucous membranes. The patient was treated for an infection by her GP the previous week. What is the diagnosis? I'll give you guys a little time to answer that. Okay, so the answer to this question is a toxic epidermal necrolysis. So I think before I actually go on to this question, I've got one other SBA before I go through why it's what it is. So SBA8, a 35-year-old man comes to the GP because of a painless maculopapular rash on his upper torso. 1 month ago, he was admitted to hospital for severe depression with suicidal ideation. He was successfully treated for this episode and his regular medication was changed. He is unable to remember the name of the new medication. His past medical history is significant for bipolar disorder, post-traumatic stress disorder, and anxiety. Which of the following drugs is the most likely cause of his current symptoms? The two SBAs are linked to one another in terms of the answers. So I will go through them in a bit. Okay, so the answer to that question is lamotrigine. Okay, so SBA7, the answer was toxic epidermal necrolysis. What that is a type of immune skin condition, basically, that causes necrosis of your skin. And that is a more severe form of Stevens-Johnson syndrome. Stevens-Johnson syndrome is basically the same thing, where you get this necrosis of the skin, but you get less skin involvement. So they're basically the same disorder, but at different spectrums of the severity, of different spectrums in terms of its severity. So in this case, you've got this extensive blistering, necrosis skin, and it's affecting her whole body, including her mucous membranes. So that's a lot of skin. That's her whole body being affected by this issue. And she's gone up to ITU as a result. So that's toxic epidermal necrolysis. In SBA8, you get this painless maculopapular rash. Now, the psychiatric history, what that is trying to suggest is he may be on I think that was actually, sorry, so lamotrigine, sorry, is the only medication in, well, one of the most likely medications in this list to cause Stevens-Johnson syndrome. So that is a what's the word, that is a one of the side effects of lamotrigine. And he's got bipolar disorder, he's got post-traumatic stress disorder and anxiety as well. So he might be on this medication. And he was also, I think, he was unable, and he was also started on a new medication. So I'm rereading the SBA. But the point of this SBA is saying that lamotrigine is a key side effect. One of the key side effects is Stevens-Johnson syndrome. And what you get is he has this painless maculopapular rash on his torso. And one thing that you're scared about is, will that rash then progress into, say, Stevens-Johnson syndrome, and then even worse, going into toxic epidermal necrolysis? So if you get people who are on this medication and they have a rash, you might want to stop. You might want to think about stopping it. So what is Stevens-Johnson syndrome versus toxic epidermal necrolysis? So as I mentioned, they're rare skin conditions that happens as a result of an immune reaction, and you basically get a necrosis of your skin and mucosa. Now, with Stevens-Johnson syndrome, you get less than 10% of skin detachment. With toxic epidermal necrolysis, you will get more than 30% of your body surface area being affected. So as I mentioned, they're the same condition, basically, it's just different scales in terms of the severity. And there's this kind of overlap layer where 10 to 30% of your skin might be involved, in which case you kind of get a blurring between SJS and TENS. Now, the most common cause is drug-related, and so penicillins, antiepileptics, allopurinol, sulfonamides, they're clear medications that may cause these conditions. So it's just something to be aware of. And again, this does sometimes come up a lot in SBA land. What you tend to get is, in terms of the presentation, so you might get, so often in the history, you'll see that they'll be on this new medication, usually for more than a month or so, or maybe even a few days actually. They'll be feeling feverish, they might be feeling a bit sick, might have a sore throat, might have these kind of prodromal symptoms, and then they'll erupt into a rash, and that will just gradually extend. And then you might then, if towards the sort of more severe end of the spectrum, you might get their skin becoming more flaccid and essentially peeling off. So you might get Nikolowski sign positive, where, as I mentioned before, you press on their skin and the skin basically comes off. Now, how you treat this is with IV immunoglobulins, basically. So you just want to overload their body with immunoglobulins to help try to reverse that immune reaction. I just put this mnemonic of some of the other of the mnemonic that I learned during med school, which is Satan, and you don't necessarily need to remember all of these medications, but some of the key ones basically. These are drugs that can cause Stevens-Johnson syndrome or TENS. So just be aware of them. And in fact, interesting, mycoplasma pneumonia is also related to Stevens-Johnson syndrome. That might be a weird SBA to come up. One other emergency dermatological condition I wanted to make you guys aware of was eczema herpeticum. So eczema herpeticum is a infection caused by HSV, and you get it with people who have a background of eczema. And so what you get is this extensive crusting papules and vesicles, and you might get some blistering. They might present being systemically unwell with a fever and general tiredness. The key thing with here is you want to treat with IV acyclovir. You might also want to give antibiotics on top if you think that some of these lesions are infected. The key thing here is you want to hold off any topical steroids, actually, because that's just going to worsen their infection. And you want ophthalmologists to see them, because you can get eye involvement with this quite quickly. So you want to get ophthal's opinion to make sure there is no eye involvement of the HSV. SBA 9, a 25-year-old male is brought to the emergency department after escaping from a burning building. Physical examination reveals burn injuries on the anterior and posterior surfaces of the right arm, anterior and posterior right leg, chest, and abdomen. The patient weighs 50 kilograms. Which is the most appropriate fluid management in this patient? I'll give you guys around 40 seconds actually to answer this question. Okay, so what is the answer to this question? So this is a hard question if you basically don't know what the formula is. So the answer is D, and let me go over why that's the case. So basically, when someone comes in with a severe burn, what you find is that their capillaries tend to be really weak. And so what you want to do is you want to fluid resuscitate them. You want to give them a lot of fluid, basically, to try to ensure their fluid balance is maintained. So there's something called the Parkland's formula that is used in burn victims to calculate how much resuscitation and maintenance fluid they need. And this is what the formula is. So you use percentage body surface area affected times by weight times by 4 milliliters per kilogram. So in terms of trying to find the percentage of the body surface area affected, there is this diagram that you need to use, basically. So one side of the arm counts as 4.5%, both sides of the arm counts as 9%, and your front it counts as 18%, and one side of your leg counts as 9%. So you can see it in the graph. So in this scenario, he had his leg affected, both sides. Which was it? It was his right leg, his anterior and posterior right leg affected. So both sides of his right leg affected. So that counts as 18%. He had both sides of his right arm affected, which counts as 9%. And he had his chest and abdomen, so his whole front affected, which counts as 18%. So his total body surface area that was affected was 45%. You times that by his weight, which was 50, and you times that by 4. So essentially, you're going to give, so 50 times by 4 is 200. So you're giving 45 milliliters times 200. So that's the total amount of fluids that you're going to give over 24 hours. Now, when you prescribe it, you give the first half over 8 hours, and then you give the next half over 16 hours. Again, you won't have got this right if you don't know the formula. Basically, it's just learning that formula, and it's something that I had to learn during med school. You might not need to know in your own individual med schools, but yeah, this is the formula that they will use often in burns victim to figure out how much fluid resuscitation to give them. SBA 10. A 14-year-old boy comes to the emergency department because he was caught in a house fire 30 minutes ago. His respiratory rate is 35 beats a minute, and his oxygen sats are 88% on room air. His estimated total burn area is 75%. His nasal hairs are singed. Which of the following is the most important next step in the management of this patient? Give you guys a few moments to answer that. Okay, so the answer to this question is C. So this patient, again, not a burn patient, but he's come out of a house fire. His respirate is very, very high, and his O2 sats are low. So he is showing signs of someone who is in respiratory depression, being hypoxic and tachypneic. And the key thing with these patients is they are at high risk of airway obstruction as a result of essentially swelling in their airways from breathing in breathing in the fire, but from breathing in whatever is burning around him or her. And so what you want to do with these patients is basically intubate them as soon as you can because they're at high risk of airway obstruction. And he already looks like he's going towards that way just because of his respirate and O2 sats. So he's in respiratory depression. So what you want to do is intubate these people as soon as possible to prevent any airway obstruction. Going down the same vein, so when you have these burn patients, you want to intubate them, you want to catheterize them early as well, so you're assessing for their fluid balance, and also mentioned their fluid resuscitation is going to be needed. Now I'm going to quickly go over this spotter as well. I'm going to give you guys about 10 seconds to think about what these images are. So we've done the SBAs and the main content of this presentation or this teaching session. Now I've got a few spotter questions. So these are pictures that I'm going to show up, and I want you guys to think what it is. I'll give you guys 10 seconds for each picture before I go through them all. So this is a picture of someone who has poor diet and gingivitis. That's the only hint I'm giving. So this picture, this is quite a mean one, but this picture is scurvy. So in scurvy, apparently you get these perifollicular hemorrhages, so these sort of redness around the follicles. You get corkscrew hairs, and you might also get ecchymosis, so larger areas of bruising. That's quite a hard one. I've never personally obviously seen scurvy, but yeah, that's what that was. Next one. The only hint you're getting is that this person has leg swelling. So what this is trying to talk about is pretibial myxedema. So you get that in Graves' disease. So Graves' disease, just a side note, is one of the big main causes of primary hypothyroidism, when you get antibodies against your anti-TSHA receptors. One of the key presentations is this thing called pretibial myxedema, so you get swelling above the lateral malleoli. What you tend to find is this non-pitting edema. You get this darkening of the skin, and you might get this orange peeled hair follicles, which sounds really weird, but yeah, that's how it usually presents. Next one, this rash. What do you guys think of this? Is just the only hint I'm giving you is that this person has a dry cough. So what this is trying to say is this is a picture of someone with lupus pernio, which you see in sarcoidosis. So I appreciate the fact that this is going all online and through images, but this is actually a raised lesion, and it's sort of purple plaque-like that you will see in a lupus pernio, and you get this sparing of the nasolabial fold. Differential for it is a malar rash, which you will find in what is it? Oh, I forgot what you find malar rash in. I think it was not sarcoidosis. You get it in lupus. Sorry, you get lupus, you will get a malar rash. But malar rashes tend to be more flat, and again, it does spare the nasolabial fold. Now, erythema, there's a bunch of different types of erythema. These are 3 images of different forms of erythema. If you can see if you can label each. So this rash is erythema multiforme, often caused by mycoplasma and HSV. This is erythema marginatum, so you can see a lot more indistinct border and more kind of look like more indistinctive borders and spread out a lot more. And you tend to get that with rheumatic fever and erythema migrans. I think they call it sort of the bullet? Or no, bullseye, sorry, a bullseye lesion. And you'll often see this with Lyme disease. A key erythema is this rash known as erythema nodosum. With this rash, it tends to be actually very painful, and it's due to a bunch of different causes, often drug related, so oral contraceptive pills, pregnancy as well, malignancy. You might find erythema nodosum, and again, you tend to find it in the shins. It tends to be very tender and quite shiny. So that's another type of erythema. So you've got erythema nodosum, erythema multiforme, erythema marginatum, and erythema migrans. And that concludes the end of this teaching session. If you guys please wouldn't mind filling in the feedback forms by accessing this QR code, you guys will get the slides once you fill out the feedback form, and I'd really, really appreciate it because it's really useful for me to know where I'm doing well and where I need to improve in terms of my teaching. So once you fill in the form, you get the access to the slides. And if you have any questions, please feel free to email us. Thank you very much.